Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. Today, we will be giving an overview of Enhanced Barrier Precautions, or EBPs. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. And you can also raise your hand to request to be unmuted to ask your question out loud. We invite you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we will be having an open Q&A on all topics with a focus on immunizations. If you have a question you would like us to discuss, you can submit it in advance using our online form, and I will drop the link in the chat shortly where you can do that. The webinar will be the same time and place next Wednesday at 2 p.m. I'd also like to tell everyone on today's call a bit about an exciting grant opportunity that we have this year. Quality Insights is turning 50, and to celebrate, we're offering a $100,000 grant to invest funding back in the communities we serve. If you or someone you know is involved in a health-related project such as provider care, grassroots outreach, education, or research, we encourage you to check out our website, qualityinsights.org/50webinar. And I will drop a link in the chat shortly for that. And there you can see the rules for eligibility and how to sign up for our webinar on how to craft a competitive application. And that webinar will be on Tuesday, May 2nd at 2 p.m. And now Jean Storm is going to share her screen. I'm going to introduce her so we can get started with today's webinar. And it looks like I forgot to introduce myself earlier. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. And now I'd like to introduce our guest today, Dr. Jean Storm. Dr. Storm is medical director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. She most recently served as associate medical director for Optum United Healthcare. She has also served as regional medical director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again.
Thanks so much, Kathy, and thanks everybody for joining us. Recently, we've gotten a lot of questions on enhanced barrier precautions. So we wanted to conduct a webinar today, and I'm going to talk about a case, but I would encourage you all, if you have a challenging case around enhanced barrier precautions, to go ahead and save it for the end and share it so everybody can learn. So the objectives for today, we're going to talk about a brief history of MDROs, multidrug-resistant organisms. I know we've heard a lot about these and we deal with them on a daily basis in long-term care. So we're going to do a brief overview because we really are focused on MDROs with enhanced barrier precautions. So we're going to talk about how they're spread. We're going to talk about colonization a little bit, infections, and who is at risk for MDROs. We're going to talk about the CDC's rationale in recommending enhanced barrier precautions. And then we're going to talk about the guidelines and implementation of enhanced barrier precautions in the nursing homes. And this has been the subject of a lot of questions lately. Anything that's new brings up a lot of questions, especially in long-term care, because we have so much going on. I mean, there's so much documentation and there's so many procedures to follow. So it's really natural to have a lot of questions about a new procedure. So we'll be going through that today. So patient case, this is a 64-year-old female. She's admitted to a skilled nursing facility from the hospital after a stay for sepsis and chronic kidney disease. Hemodialysis is initiated during the hospitalization. So she has a tunnel dialysis catheter that's placed. 26 days after her admission to the nursing home, she's found to have a temperature of 100.2 and a heart rate of 108. So we know with sepsis tools, the easiest one to remember is 100, 100, 100. And here we have a temperature greater than 100 and we have a heart rate greater than 100. So we know that she's looking like she's septic. So we try to keep the patient in the facility and initial labs are drawn, but she is unresponsive the following day. So this is common, right? This happens a lot, especially with our hemodialysis patients. They have a change in condition very rapidly. So she is sent to the hospital and diagnosed with MRSA bacteremia from a dialysis catheter associated infection. So is this preventable hospitalization? Perhaps if we would have used the right precautions like the CDC recommends. So just as a review, what is a multidrug-resistant organism? These are typically bacteria, though we've been seeing a lot about a Candida species that's been resistant recently. I'm sure you've seen it in the news. So these bacteria are typically bacteria that are resistant to one or more classes of antibiotics. These are the bacteria that when you see a urine culture and you see R, meaning it's resistant to most of them, that's when you know you have an MDRO. These organisms are frequently resistant to the most common antibiotics. They're associated with longer hospital stays, increased costs, higher mortality. These make people really, really sick, and they're hard to treat because, as I've said before, when we have individuals in the nursing home, sometimes they have allergies to medication. So it's very challenging to pick an antibiotic that is suitable for them. And if we have a resistant organism, that narrows the antibiotic down even further. And then if we have compromised renal function, then that will narrow the antibiotic down even further. So it really limits our choice. And the prevalence of MDROs have increased a lot over the last few decades, especially in nursing homes, and probably that is driven by the number of antibiotics that we prescribe in the nursing home. So antibiotics are causing resistance. So when we look at colonization versus infection, colonization means that we have a potential bacteria present on the individual's body, may not be causing an infection. It increases risk for infection. So like our patient with the tunnel dialysis catheter, she was in the hospital, so she might have been exposed to MRSA. Perhaps she had it on her body, she was colonized, and it put her at risk of developing infection, and that's what happened. So individuals who are chronically ill, like patients who are on hemodialysis, immunosuppressed, or they've been recently admitted to the ICU, they are at increased risk of developing infections from bacteria that are already on their body, that they're colonized with. So what is the rationale for using enhanced barrier precautions? Our residents are at increased risk of becoming colonized with MDROs and developing infection. So we want to prevent colonization if at all possible, because we know when they're colonized, they're at increased risk of developing infection. We do know that about 50% of our nursing home residents may be colonized with an MDRO. So if we only look at infection, at residents who have an active infection, then we're really not looking at prevention. And when we think about prevention, what we really want to think about is transmission. So we want to prevent MDROs from being transmitted from one resident to another. So there's growing evidence that traditional implementation of just our regular old contact precautions in nursing home is not going to prevent MDRO transmission. So enhanced barrier precautions refer to the use of gown and gloves during high contact care, resident contact care activities. And so what really is happening, you think about when you provide resident care, say if you are changing a resident, you know, when you kind of roll that resident over and perhaps they roll against you, you might get an MDRO on your scrubs and whatever you're wearing. And then you move on to the next resident and do the same thing. And then you transfer whatever is on your scrubs to the next resident. So that is the rationale behind enhanced barrier precautions. That's why we're using a gown and gloves, and then just for the resident care that we're doing, and then we're throwing it out and moving on. MDROs may be indirectly transferred from resident to resident during these high contact care activities. So who are we using enhanced barrier precaution? What residents? Is it all residents? So we're using enhanced barrier precautions in residents who have wounds and indwelling medical devices. So they are very high risk of acquisition and colonization with MDROs. So we're using gown and gloves for high contact resident care activities. So this is when contact precautions do not otherwise apply. This is for residents with wounds, indwelling medical devices, regardless of them. We don't care if they're colonized with MDRO. We are just going to utilize them if the resident has a wound or an indwelling device. And also we would be using these for residents if we know they have an MDRO infection and we know that they're colonized. So for an individual that has a wound and an indwelling medical device, irregardless of if we know if they're colonized or not, we're using the enhanced barrier precautions. And then for residents that we know have an MDRO infection or we know that they're colonized, we're also going to be using the enhanced barrier precautions. So what are our examples of high contact resident care activities? Getting a resident dressed, bathing and showering, transferring, providing hygiene, brushing teeth, combing hair, shaving, changing a brief or assisting with toileting, changing linens. Device care. So anytime we are changing a urinary catheter, we're changing a feeding tube, we're changing a trach, we're changing a central line, we should be using enhanced barrier precautions during this care. And then wound care. CDC has a really great informational site about which type of wound care we should be using enhanced barrier precautions for. And then physical and occupational therapy as well, because sometimes that is high contact. So chronic wounds. So the intent of enhanced barrier precautions are to focus on residents who are at high risk of acquiring an MDRO over a period of time. So this includes residents that have chronic wounds. So we're not talking about skin tears. We're not talking about skin breaks. If they're covered with a bandage, we're not, that's not what a chronic wound is. So pressure ulcer, diabetic foot ulcers, unhealed surgical wounds, chronic venous stasis ulcers. All of those would be included in an individual who would be getting enhanced barrier precautions with care. So our indwelling medical devices, central vascular lines, our hemodialysis catheters, or if the patient has a indwelling urinary catheter, if they have a feeding tube, if they have a tracheostomy tube. So things to consider about enhanced barrier precautions. So it's enhancing the current standard and transmission-based precautions. So we're just putting another level in place to prevent MDRO transmission between residents. So during care, we're going to use gown and gloves for each resident during high contact resident care activities that I talked about. And then when you are finished with the resident care activity, you're going to take off the gown and gloves and you're going to move on to the next resident. Obviously, we're going to perform hand hygiene in between removing the gown and gloves and then moving on to the next resident. So it's not recommended for residents with C. diff. These residents need to be on contact precautions and isolation as per your facility policy. Residents do not require a private room because this isn't something that's going to be limited. These patients are going to typically have enhanced barrier precautions for the amount of time that they are in the facility, and they're not restricted to their rooms. So this is not isolation. So if a resident is colonized with a MDRO in their urine, they have ESBL in their urine, and they get treated, you're not going to isolate them to the room forever, but you are going to use enhanced barrier precautions just because they are colonized with an MDRO. So more things to consider. It's intended to be in place for the duration that the resident is in the facility until if the wound is resolved or they have the tunnel dialysis catheter is removed and they have fistula placed. So if that is resolved, then we would go ahead and get rid of the enhanced barrier precautions. Though if they're colonized with an MDRO, we would not. So it does not replace existing guidance regarding use of contact precautions. So it's intended to provide care when a resident is in their room during high contact resident care activities. So including transfers. This does not mean that we're going to use enhanced barrier precautions when the resident is in the dining room. We are not going to use it when they're out in other areas, except physical therapy and occupational therapy. So does enhanced barrier precautions work? So if you're like me, sometimes things get put in place and you question. I'm a curious person, so I want to know, does it work? Like this sounds wonderful. It sounds like it's gonna it would work. But let's look at a study to see if it works. So they did a study, and this was published in JAMA Internal Medicine in 2015. So the study looked at enhanced barrier precautions utilized in over 200 residents that had indwelling devices in 6 different nursing homes. So it was a good study. It was a good amount of individuals, and they compared it to a control group of also a little over 200 residents. So barrier precaution signs were placed on the doors to their rooms, inside the closets, and at the nurse's station on their medical records. So everybody was aware that enhanced barrier precautions needed to be utilized during high contact care with these residents. It also included active surveillance for infections and MDROs. They also promoted hand hygiene and structured infection prevention education in the control group. And the infection preventionists and the intervention facilities were invited to a conference on surveillance methods for infection. So a really great study. So what happened? There was a 23% reduction in the prevalence of all MDROs in the intervention group. So that's pretty significant. This is compared to the control group that didn't see that reduction. So when enhanced barrier precautions were used in these patients, they had a 23% reduction in the prevalence of all MDROs. There was a reduced incident of new MRSA acquisition in the intervention group compared to the control group. So another great thing, MRSA is probably the most common MDRO that we see in our nursing homes. So this is huge. There was also a reduction in catheter-associated UTI in the intervention group compared to the control group. Another pretty significant finding. Okay, so we know it works. So does the patient require a private room? No. So single patient rooms, as we all know, should be prioritized for residents who have acute infection with a communicable disease. So that's influenza, COVID, hepatitis A, or for residents, if we have a private room available, for residents placed on contact precautions with acute diarrhea, if they have a draining wound or other site secretions and are unable to be covered or contained, if we have a private room. So shared rooms. Residents who are on enhanced barrier precautions may share a room with other residents. So facilities with capacity to offer single patient rooms or create roommate pairs based on MDRO colonization may choose to do so. This is fantastic if we can do that. If we know that a resident is colonized with an MDRO, and we know that there's another resident who is the same MDRO colonization, and if we can have them be roommates, that's wonderful. If there are multiple residents with the same MDRO in the facility, consider cohorting them in one wing to decrease spread. Sometimes this is possible, sometimes it's not. I know it's very challenging and it makes for creative room moves. So if possible, that this would be wonderful. So when single rooms are not available, we want to cohort patients with the same MDR in the same room. Oh, I think this is this is a duplicate slide. So, when cohorting patients with the same MDRO is not possible, we want to place MDRO patients in a room with patients who are low risk for acquisition of MDROs. So that means if we have a patient with an MDRO and we can't cohort that patient with the MDRO in with another patient with the same MDRO, we want to put them in a room where the other resident has a low risk for acquisition of an MDRO, and associated adverse outcomes from infection. So these are people that are not immunocompromised, that are of no open wound. So we don't want to put a patient who has ESBL in their urine into a room with a patient who has no MDROs and has an open wound. So we want to kind of think about these things when we put patients together as roommates. So signs. These signs are available on the CDC website, and the link is there. I don't know if we're all wore out with signs, but this is really helpful so we understand why we're doing what we're doing. And if you can share with staff that study, it's really significant. It made a big difference in a lot of patients' lives. And if we can prevent patients from going out to the hospital, that's fantastic. You know, MDRO infections are significant, especially in patients who are immunocompromised, like our dialysis patients. So patients can die. So this can prevent a patient from dying. So it's significant. So, you know, we put these signs inside the patient's room, inside the bathroom, at the nurse's station, so everybody is aware of what we should be doing. So again, these are just to signal to individuals that specific actions should be taken. And this sign is really great because it shows you exactly what you should be doing, in what order, and what you should be putting on. I don't know about you, but at the beginning of the pandemic, I was really happy to have these signs because the donning and the doffing was challenging at first. Even though I had been tested on it at some point in my training, I had to get tested on it again in the nursing home. So putting up signs has really been shown, especially signs that list a checklist of the series of events that an individual, a staff member should go through for the PPE have really been shown to work. So I would highly encourage you to use these signs in your facility for enhanced barrier precautions. So we want generic signs, the generic signs, generic signs that just instruct individuals to speak to the nurse are not adequate. And I don't know if anyone, I don't think those are effective. It just says, please, talk to the nurse at the nurse's station. It's really important to make sure that what staff need to do is listed on the sign. And obviously we're not going to include any information about why the sign is there. We can't do that in the facility, obviously, due to privacy. And it's a HIPAA violation and a violation of resident dignity. So we always want to make sure we have our resources. Again, as I said, the CDC has a lot of resources. I would go directly to their website if you'd like to download any of that material. Or you can feel free to reach out to me. I'd be happy to help you navigate. A couple people have actually already reached out to me about navigating enhanced barrier precautions, and I'm happy to answer your questions. I always learn when somebody asks me questions, so I'm happy to answer them. So these will be available in the slides. And any questions? This is Lightning Storm, who is very quiet during the during the presentation, so I'm happy about that.
Thanks, Dr. Storm. So we've already got a couple questions in there, so we can dive right in. First question, it says, in regards to garbage / dirty laundry and linens, do we require biohazard, urinary MDRO, incontinence briefs?
So I don't know what. Can I read the question?
Now that one's in the Q&A if you'd like to be able to read it.
Okay. In regards to garbage, dirty laundry, and linens, do you require biohazard? No, I don't believe so. Maybe one of the experts on the call can answer that as well, but I do not believe that it is a biohazard. No, urinary MDRO. Go ahead.
Hi, yes, this is Jennifer. The biohazard is not recommended for materials that are not dripping with soiled blood or anything like that. So regular things that have dirty laundry, garbage that have been in the room do not need to be in a biohazard bag.
Okay. And then urinary MDRO incontinence briefs. This is the first time I've heard of these urinary incontinence brief. Jen, I don't know if you've heard of those. I don't know what's in them. Kelly, I don't know if you want to unmute and tell us what's special about the urinary MDO or MDRO incontinence briefs, but I have not heard of those. I would think if it was just an regular brief that would be fine to use. I haven't seen any research about the efficacy of those.
She says, I mean, a used incontinence brief of a resident with an MDRO. I
would just dispose of it in the normal fashion that you would normally dispose of incontinence briefs, but that sounded exciting, right?
See, we're getting lots of questions and hands raised.
I thought they were like embedded with silver or something.
Getting lots of questions, so we'll get to all of you.
Yeah, it's dispose of them in the normal fashion.
All right. Let's go ahead and take Mary's question. Mary's got her hand raised. So Mary, you can now unmute yourself to ask your question. If you would like to ask your question. Sometimes people hit the hand raising by accident, so you can lower your hand if you don't want to ask your question. Okay, we'll move along then. Okay, the hand's lowered. Next question. My facility is 192 beds. We take many admissions with pressure injuries. It is not uncommon to have 30 to 40 residents with a PI plus catheters, tube feed, etc. I must admit, it seems unmanageable to have 40 to 50 residents on EBP at any given time. Do you have any advice on how to successfully implement these precautions and maintain compliance?
So I agree. That does seem, it seems unmanageable, but I don't think it's impossible. I'll say in that study, they had a lot of success because they talked to, I think that they were able to cohort residents and put them in one area. So they talked to the staff that were taking care of those residents and gave them little laminated cards. So staff understood exactly what to do. They got the medical director involved. They got the infection preventionist involved, obviously. And so they had really good compliance in those facilities where they implemented this. I would really make sure you get everybody all hands on deck. Like the medical director needs to be involved and make sure, understand so that everybody can kind of support each other. Like we're doing this because we need to help keep these residents safe. So, yeah, if you want to check out that article, it describes the whole series of events they went through to educate staff.
We have another question. I think it's pretty similar, so maybe you covered this already. It says, my facility is a long-term vent facility. Per the guidelines, EBP would apply to over 90% of residents in a 150-bed facility. Would you have any recommendations for implementing EBP? I'm not sure how this would be possible given the sheer amount of gowns needed, how to store, how to make them accessible, etc. I am waiting to hear back from our local DOH, but I would look towards any help.
Yeah, I would encourage you also to reach out to your DOH. And if we can, we'll get together and talk about this. I thought about this, about the number of gowns, because obviously we're just coming out of, we're kind of easing to the end of the COVID pandemic. And, we used a lot of gowns. So yes, I agree, but I would continue to reach out to your Department of Health and see if you can get any help in that regard. And certainly we'll put our heads together. And if we can think of any resources, we'll reach out to you.
Thank you. And one more question that we have in the Q&A is, any recommendations for PPE, but keeping with the home-like environment? And she also said that your puppy is cute.
Yeah, it's really, really challenging. I don't know. I'm sure they make gowns that look nice, but I bet they are more expensive than regular gowns. Yeah, it's really unfortunate. They just used in the resident room, so that's one thing. So yeah, I would, I don't know. Perhaps you can get creative with gowns.
She said, sorry, I meant storage of PPE.
Oh, storage is,
And I guess any recommendations for storage of PPE, but keeping with the home-like environment?
it's really challenging, right? Because everybody, yeah, because you have those, what I've seen are those plastic bins. I'm sure that there's a better way to do it. Maybe get creative with staff, or I don't know. I always feel like to ask residents, I get the best recommendations. So maybe at your resident council meeting, you can kind of explain what you're doing and that you want to make these bins look nice, and have residents, give some input. They might want to help decorate the bins, however, you can do it, because obviously they're just like the bins outside the room. So yeah, maybe ask activities to get involved with in resident council.
One person said in the chat, we have one centrally located cart in each hall.
Yeah, that's a nice idea.
Thank you. And then one more question in the chat, or sorry, in the Q&A. It says, also, can EBP be discontinued if a urine culture comes back negative of a colonized resident? So
that's an interesting thing. If you have so I don't know if the resident is colonized. So this is going to really depend on where so if you're saying the resident is colonized and you're saying their urine is negative, then perhaps they are not colonized. Their urine is not colonized. So if their urine is negative, no organisms, then you don't have a resident who's colonized. So then you could get rid of the enhanced barrier precautions. You have to be certain that they're not colonized in other areas. So I don't know if you're checking NARIs, other areas, to make sure that they're colonized. A lot of the times we're not, right? We're not doing that full check to see if residents are colonized. But in this case, if you're certain that the resident was colonized in their urine and you have a negative urine, no organisms, then yes.
Thank you. And then we had, in addition, that the PPE storage must be, CDC says it must be located immediately outside the room. The questioner just wanted to add that.
Gotcha.
And that is all the questions we have so far, but if anyone else has a question, it's not too late. You can either raise your hand if you'd like to ask your question out loud, or you can drop it into the chat or the Q&A, and I will just run over some quick closing items while we wait. Let's see. Okay.
This is Penny. I did just want to mention for Rebecca that I do know in one nursing home I work with, they actually, the carts that you have to outside the room because the person needs isolation, they did like a nice cart with a colorful covering, and then people could, so when it sat outside the room, it looked nicer. It really is hard to do that person-centered home-like culture and try to keep infection control, but there are things, and I thought, Jean, that's an excellent idea. When you get the residents and activities involved, sometimes they can come up with some really good ideas for how to make things look a lot more home-like.
Thank you, Penny. And that's Penny. She's our nursing home team lead. And earlier you heard from Jennifer Brown, who is our infection control preventionist. I didn't get to introduce them earlier. Well, okay. Yeah, so getting back to like the closing items, if you do have a question, it's not too late. You can put that in the chat. I'd again like to invite everyone here to next week's webinar, which will be a live Q&A on all topics with a focus on immunization. So like this webinar where everyone's submitting their questions, that's another opportunity to give us your questions. And you can submit them in advance with the form that we have, and I'll put that link in the chat again. And that webinar will be next Wednesday at 2 p.m. And we also invite you to bring your questions to our virtual live chats, which are each Tuesday and Thursday at noon. And Deborah Wright will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. And you can find the link to join those live chats in our webinar email reminders, as well as our last minute lowdown newsletter, which goes out each Friday. And if you're not on our mailing list to receive those emails, you can message me to be added to our list. My email is ccaudill@qualityinsights.org. And I will put my email in the chat shortly, along with Dr. Storms. And looks like we might have a couple more questions. One person asked if we were going to be emailing or if we're going to have these slides available to download. And the answer is yes. I will be emailing them to everybody later this week, along with the recording to the webinar. And I'll be sending that to the email that everyone used to register. This new question says, if we have someone with an active MRSA in the NARES, is that the right word?
NARES, yeah, the nose.
You guys like to trip me up. If you have someone with an active MRSA in the NARES, the EBP would stay through the duration of their care. Is that correct?
Yes, they are colonized with MRSA, so correct. Yep.
Let's see, and I think that might be it. That's the last in the Q&A, and I believe that's the last in the chat, and I don't see any hands raised, so I think we can wrap up. And as I said, there's lots of ways you can get your questions to us if we didn't get to you today. Oh, let's see. Someone asked, I will not be available for the webinar next week. Would I still be able to access it after Wednesday? You can contact me if you'd like to be emailed the recording. I hope that would be helpful. Actually, anyone, if you just register for the webinar, I email the recording to everyone who registers. So even if you don't plan on coming, that gets you on the list to get sent the recording from me on Friday. Someone said, if you recheck the NARES and it comes back clear, you can remove the EBP.
Yes.
All right, thanks everyone for this great discussion. I hope that I got to everybody. I think that I did. All right, so I'm going to go ahead and wrap this up real quick. Before we sign off here, I'd like to ask everyone here to please answer a short evaluation of today's webinar. The evaluation is anonymous and it will show as a pop-up as soon as this webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. I'd like to thank all of you for joining us today and for all of those great questions. And Dr. Storm, I'd like you to thank you for joining us again today. And we hope to see you all back here next week.